really, though, it's how quickly can a family catch this? And if they're following some of those things, right, they're all sitting down to meals together, they're going to notice sooner when the behaviors seem odd, right? So if your kid is always eating in front of the TV and everyone's eating at other times, you might not notice right away that they're throwing out half of their plate until you go to the doctor and you see kind of, oh, they haven't gained any weight. Because even some of that, right? We know kids all grow differently. So parents don't necessarily know how their kid should be growing day to day. And so when they go for that once a year appointment and see that change, that might be, again, not too late, but where it's become more of a severe issue.
Picky eater is one of the most common labels in pediatrics and one of the easiest to overlook. But when a child's diet is shrinking instead of expanding, when meals are a source of stress instead of routine, or when growth and nutrition start to feel like a question mark, it's worth taking a second look. In this episode, we're discussing ARFID, what it looks like in clinic, how to spot the difference from typical picky eating, and how to approach these patients with a sharper clinical lens. This is Charting Pediatrics. To discuss this important topic, we are joined by Dr. Kimberly Sheffield. She is an eating disorders psychologist here at Children's Hospital Colorado, as well as the clinical director of the PMHI, the Pediatric Mental Health Institute day programs, and the associate training director for psychology training. Kimberly, welcome to the podcast.
Thank you.
So let's start out by defining what ARFID is for our audience.
Yeah, so we love an acronym, right? And so what that breaks down to is avoidant restrictive food intake disorder, which is really this category of eating disorders. It's a newer one. So we've only had this diagnosis since the 2010s, so a little over a decade now, and really came from this need to capture this group of kids and adults who have these restrictive eating patterns, but it's not related to a desire to change their body shape, to lose weight, that it's really driven by other reasons that eating is hard for them.
Yeah, I mean, I find it so interesting that this is a new diagnosis, as you said, about 10 to 15 years ago. And what it leads to in my mind is this something we just weren't capturing, or is this an environmental insult for those who may have been prone to this?
So I think it's a little bit of both. I think that we were not capturing these kids. And by that, I mean not past a certain age. So I think these were kids who early on we give maybe at least a portion of them the failure to thrive label, right? Because some of the kids with ARFID, it really is this low appetite, kind of low interest in food. Maybe they were always small. And then as they get older, they really start dropping off the growth curve. And it's this idea of early on, we do feeding interventions and really focus on that. But later, there really needs to be a shift to more of these behavioral interventions and focusing on how can we support kids and their parents in really increasing their food intake and challenging whatever it is that's making it hard for them to eat.
There is an increased incidence genetically for some people, isn't there?
Yes. Yeah. Yes. And we know that to be true of all eating disorders, that they're a bit of a mystery, but there's definitely a genetic component. And so we often hear from families that there are multiple family members with more of these picky eating patterns, which again, like that's a genetic component, but also there was maybe limited exposure to a variety of foods in their household if their parents were more kind of picky eaters.
Yeah. I mean, you're mentioning picky eating and, this comes up all the time in primary care. Help me understand when we're thinking, well, this is just some picky eating versus this is something much more serious, maybe ARFID.
Yeah. And so I think of it as really when it persists and when it's starting to impact growth. So we're really concerned about these kids once they, again, in kids, it's not necessarily that they're even losing weight, but these are kids who stop gaining weight. So I'll see a 14-year-old who really hasn't had a shift in weight since they were 10. And that's when it's concerning, right? Because then we're concerned about them losing height trajectory. In females, we're concerned about delayed onset of menarche and any of the impacts that's going to have on their body. And so then the picky eating is really something that's going to impair their growth. It's not just I only eat a few foods, but I eat enough of them. It's I only eat a few foods and I'm not getting enough of them to support my development.
Yeah, I mean, I've been reading a little bit about it, and one of the distinctions can be, I'm not eating enough versus I have an aversion to the smell, taste, those types of things. And then the last one is help me. A fear of something awful happening, like choking.
Yep. Yeah. So that's exactly it. We think of these kind of three main categories. Then there's even been talk of making them more official subcategories in future diagnostic manuals. But really this idea of we have that first, the low interest, low appetite kids. The second being sensory aversions, often kind of a high rate of that in our kiddos who have neurodevelopmental disorders. And we can talk a little bit about that overlap. Right. And then that third category is that more what I would call like an acute onset of fear of aversive consequence. So that can be abdominal pain. A lot of those kids wind up in GI clinics, but it can also be more of like an emetophobia. So a fear of vomiting, a fear of choking, but fear of something bad happening when they eat either all food or specific foods.
Are there gender differences in terms of how they present in those regards?
Yeah, somewhat. And I think in general, it's important to know that ARFID occurs actually more commonly in males than in females, which is different than the other eating disorders we talk about. And so I think that is an important distinction. And I do see rates about equal in kind of the more acute onset, but higher rates in males for more of that kind of chronic, either low appetite or sensory challenge.
Okay. And you mentioned neurodiversity.
Yeah.
And from what I've read, 12% of kids who have ARFID also have autism spectrum disorder.
Yeah, so that's right. And I think it's important to know that there is, even within autism, what we would consider picky eating in a normative way. So, right, maybe you've heard like the yellow or the beige diet. And some of that is okay if they're getting sufficient amounts. Something like Cheerios has robust vitamins. So something like that to like balance it out, right? Or they're having Pediatric or Boost or some kind of supplement. But then there's the kids that it becomes so limited, right? I only eat this one type of French fry from this one restaurant. Like we had a kid recently where it was really just McDonald's French fries, to where they went on vacation and they had to ask the restaurant, like, can we have you make French fries in this certain way with this amount of salt? And for better or worse, the hotel actually accommodated that, which just reinforces the whole thing. But for that period of time, was able to keep getting him nutrition. And so it becomes that restricted. And we will see those in those kids with autism.
There's a little bit of debate, isn't there, among the experts in this field? Is this kind of a neurodivergency in and of itself, or is it a genetic predilection with an environmental insult? Can you comment on that?
Yeah, well, hopefully we'll know more someday and actually have some research on that. But I think that it is beyond just a neurodiversity. And so I think that there are those kids where there's that overlap, but I think there are a lot of kids that we see who they don't meet criteria for autism or ADHD, but they still have this very challenging relationship with food where there's some reason that meal times have become this aversive experience.
So I'm a primary care physician. Give me some pragmatic tools. I have a kid who comes in, and I see some, maybe not robust eating. What does my growth curve look like? And when should I be thinking about ARFID itself? Or what are some red flags in the history that I might be thinking about? Yeah,
so that's a good question. I think first off, with any of these things, right, we want to catch them earlier as opposed to later. So even with your normative picky eating, I think it's important to talk with families about how they can continue to provide a variety of foods while meeting nutritional goals. And often what that can look like is making sure that on a plate you have your kind of safe foods they're going to eat enough of to get nourished, but then having some novel foods at every meal and presenting them more than once is a big thing, right? So we know that it can take up to 20 times tasting a food for someone to develop a like for it. My son recently decided he finally likes avocado wonderfully, right? But that took a really long time, and it's just presenting it over and over, but not having the whole meal be the food they're not going to eat, making sure they're still getting nourishment while you work on food variety is one thing. So doing that with really all kids. And then I'm worried once they stop progressing, right? So if they stop gaining weight, if they are starting to have some height stunting, certainly we want to be kind of looking at that. So looking at those growth charts, looking at trajectory. And also if they are talking about how it's causing impairment for them, right? So if they are avoiding going to a birthday party or having lunch with friends at school because their eating is abnormal in a way that maybe peers are starting to notice.
My understanding is this can happen at any age, but it kind of peaks 10 to 14. Is that correct?
Yeah. And I think that's, again, because of how we're starting to see it impact puberty. So while maybe it was trending in that direction, I feel like we get a lot of kids around that age because that's when pediatricians are starting to notice, like, hey, this kid is not gaining weight as we'd expect, or hey, their height is being impacted, or in girls, they're not getting their periods. And I think that might be part of why it is. I also think parental expectations around that age, right? So if we think of our younger kids, we tolerate an amount of picky eating, and we also tolerate the parent really needing to lead meals. But around that tween age, we want them to be more independent. And so if your kid isn't having more independence in getting their own snacks, or even, a lot of families getting their own breakfast, right? Things like that. If they're not doing those things without parental oversight, I think that starts to be a concern around that age, where in a 5-year-old, we're not worried about that.
Yeah, what I'm hearing you say is that it becomes more obvious for two reasons. One is you have an increased caloric demand. Mm-hmm. So kids are really growing a lot at that age. And as a result, you're going to notice if they have insufficient caloric intake. And then the other piece is the independence around eating at that time.
Yeah, because we hear that a lot of why can't my kid just do this, right? Why is it so hard for them to do this very natural thing? It's natural for us to eat. And so for a lot of families, this idea that their kid just isn't doing it becomes very distressing.
One of the conversations I have with my patients most is around eating during toddlerhood, and especially around sort of food hygiene or meal hygiene, setting up the situation so that you're both sitting together. Parents' responsibility to pick the right foods, put those foods in front of the child's responsibility to decide what to eat and how much to eat. Is that the right way to think about it? And also, is there any way, is doing that going to help preclude ARFID in the future? Or is this just something that's completely out of our control and maybe genetic with an environmental insult?
I think there is an aspect that's within our control. And so starting with some of those, like meal hygiene things are going to be helpful. And I still think that there are some kids that are going to be more likely to develop ARFID. Really, though, it's how quickly can a family catch this? And if they're following some of those things, right, they're all sitting down to meals together, they're going to notice sooner when the behaviors seem odd, right? So if your kid is always eating in front of the TV and everyone's eating at other times, you might not notice right away that they're throwing out half of their plate until you go to the doctor and you see kind of, they haven't gained any weight. Because even some of that, right? We know kids all grow differently. So parents don't necessarily know how their kid should be growing day to day. And so when they go for that once a year appointment and see that change, that might be, again, not too late, but where it's become more of a severe issue. Because, of course, as they avoid the food, that is in and of itself reinforcing, right? So I avoid it, which makes me feel safer. For whatever reason, I'm afraid of the food. And so then I avoid it more and more and more. So the quicker we can interrupt it by having that parental oversight, the better.
All right, I'll give you a scenario. So you have a toddler and you're a primary care physician and you're seeing the toddler and there's some behaviors that maybe picky eating-ish. You don't identify anything that's egregious or worrisome at the time. And they're a little bit low on their growth curve. And as they're growing, they're getting a little bit older. Some of the behaviors seem a little bit more entrenched and a little bit worse. And maybe the growth is faltering a little bit more. So then we maybe do a history and we understand there's some oral aversion. Maybe it smells, maybe it's textures, something like that. What are our next steps?
Yeah. So I think first it's having kind of a frank conversation with the parents about these concerns and then really walking through how they are structuring meals currently. So one, making sure kids are just getting enough eating opportunities. For kids, when we want to support growth, we really want to make sure they're getting those 3 meals, but also 2 to 3 snacks during the day. Certainly depending on their activity level, that might even be more. And then making sure that, again, parents are really setting the expectation that a kid pause, sit down to the meal, because we see a ton of that too, right? Kids eating while they're in the car, kids eating while they're watching TV, while they're running between things. Parents too. I mean, it's not just kids, right? We're modeling this for our kids too. But that they're setting this expectation that nutrition is important, because that's a big part of it too, right? We are really trying to highlight that taking this pause for nutrition is just as important as making sure your kids get to kind of a regular bedtime, right? And so setting that expectation, giving them a variety of food, but also just making sure that they are completing enough food. And if they're not, thinking about ways that they can start to increase that, which is when we start talking to families about kind of the use of rewards and external reinforcers if their kid is, especially like the low appetites kids, just not interested in food.
I do worry in today's culture about the sort of the grazing mentality.
Mm-hmm.
And I do think it's important for kids to feel hunger and satiety.
Yeah.
So that really resonates with me, what you said. Okay, so we go over some of those sort of hygienic things. And what I hear you say is, making sure that there's opportunities to eat and stuff like that. Okay, we do that. We see them back. It's still a problem. What do we do next?
I think that's when you really have to get to how do the parents manage other challenging behaviors in their home, right? So always wanting to align with what are their parenting practices as much as we can. So if their kid is, especially if their kid is like refusing to sit down to the meal at all or refusing to complete the food on their plate, right? If there's a good amount of kind of refusal that's come into it, which is often the case once they get that ARFID diagnosis, that the parents know, okay, I'm going to treat this as seriously as if my kid was refusing to go to school, or if my kid was refusing to brush their teeth, right? Or any of those things that we ask our kids to do that they maybe don't want to do for different reasons, and holding the same expectations around meals, that this is something that we're going to pause, we're going to do. And, for a lot of kids, it becomes screen time. Like, we're not going to move on to the next preferred activity until we've done this. So setting a lot of structure in the home.
Okay. And, the one thing that I get worried about when I hear you say that is sort of the battle, the food battle. And so kind of sitting there and like staring at the child and being like, eat those peas, otherwise you can't leave the table. Can you comment on that?
Yeah. So it's this interesting thing actually where having some clear structure, and this we get into the detail with our families because by the time they're coming to us, the behaviors are fairly entrenched and we're concerned that we are having them set timers and really have that structure around it so the battle doesn't ensue. The parents sit down, they present the plate of food, they're going to sit there with their kid and they're going to put a timer on for 30 minutes. We're going to have 30 minutes to do this meal, which families come to us saying like dinner's taking 2 hours. So we're going to cap it 30 minutes. And at the end of the 30 minutes, like they're going to remove the food. They're not just going to keep sitting there and talking about it. And that's where, especially when kids have to grow, we introduce nutritional supplements so that we're going to have them doing Pediatric or a Boost or something like that as the way to ensure kind of they're getting their nutrition, but that we're not fighting over specific food items. So we kind of have the structure of mealtime followed by that supplemental nutrition, and that parents in that moment, they're not begging their kid to eat. They're not saying, I have to get you to eat this bite. They're just being very clear of, my expectation is you're going to complete this meal. And then once we do, we are moving on to TV time or whatever fun thing they want to do.
Okay, so we've done all those things. We have talked to the family about sort of the food hygiene, setting a timer, not making it a battle. We're following this child up. We're still having a lot of difficulty. The family's having a lot of difficulty. What are our next steps? When do we involve a specialist?
Then. So that's when we do it, right? I think that is the time. Certainly if parents are asking for it sooner, you can do it sooner because some of this is going to be outpatient therapy for general kind of parenting skills. I always tell parents, because there's a lot of guilt around, right? Why can't I do this? There's no handbook for parenting. And most parents, I'm a parent, most parents could benefit from like a parenting skills coach. And so we have groups for that. But then certainly when it's becoming more of a challenge, we have those kind of individual parent sessions that will do an outpatient therapy where you're working with a mental health provider specifically on how to address challenging behaviors, which from these kids is becoming food refusal, right? So talking about how can I structure the home so not everything is around this. So the first thing is, right, building the parent-child relationship, improving that, because often it's damaged when they're having these ongoing battles. And then working on those things like rewards charts and having really a system for motivating their kids to do these things that they just don't really want to do.
Yeah, tell me a little bit more about a rewards chart. What does that look like?
Yeah. So for these kids, often we'll have it be something where we're doing rewards. So younger kids, it's great with points. Older kids, often it's just like minutes on their phone or minutes with a video game or something like that. But where's the very clear connection with when you complete, wherever we're starting, maybe it's 50% of this meal, you get this reward, and then upping that to 75% and eventually 100%. And really, again, taking it out of the in-the-moment negotiation or bribery to a preset, this is our system. When you do this, this is the reward you get. We're not going to get into a back and forth during it. This is just the expectation.
So is this group therapy, family therapy, both?
It could be both or either, right?
Okay.
So often we will start with a group. One, it's just a way to get more people access sooner. So a lot of clinics will have a group model first. That's certainly what we here at Children's Hospital Colorado have. And then, again, if they need more specialized intervention, if there's something that's really not responding to that broader curriculum, which is usually what they use in groups, then we'll do we still call it individual therapy, but it's a parenting intervention where they really will focus in on what needs to happen in that household, because ultimately it also needs to meet kind of whatever is the culture of that household.
So we've done that for, what do you think is a reasonable amount of time? 6 months or something like that?
I usually say if a kid's not responding to those outpatient interventions, especially if they're continuing to lose weight or not grow, I actually want to know within like 2 months and maybe have them consider a higher level of care.
And what would that higher level of care be?
Yeah. So certainly we're hoping that we're catching this and we can start with just psychiatric care in a day program, but we have a lot of kids that wind up on medical first. So they'll have a medical inpatient admission because they've lost so much or they're eating so little that we do have that concern for refeeding syndrome. And so they'll start with medical monitoring, or they develop bradycardia. So they're really having those impacts of malnutrition that we see with other eating disorders. But if we've caught it soon enough, they're fairly stable. They will start with a day program, which there's a variety of different structures, but typically has them coming for, everything from like 6 to we do like an 11-hour day where they are with us and we are helping structure all of their meals and really giving that guidance to families. So the big thing with these day programs is I see it as an intensive boot camp for parents to see what it looks like when this happens. Because often parents will come to us saying, I've tried everything, right? Which I totally hear. And that's absolutely how it feels. And so they almost need it modeled for them of, okay, if we really stuck to all of these interventions, we would see this change. And by having the staff in a program kind of show them this can work, then we can help translate that into their home environment.
I think in primary care, we're very tuned into mental health. Absolutely. Mm-hmm. And sometimes we focus on organs. And so sometimes with eating, we may focus on the gastrointestinal system. And I wonder if some primary care physicians, myself included, make the mistake of maybe referring to a gastroenterologist before thinking about ARFID and the mental health.
Yeah, I think we definitely see that happens. And I think some of that is driven by families, right? So one, they just don't think of these things as being eating disorders. If there isn't that body image component, they don't think, okay, my kid's avoiding food for a psychological reason. They think there must be something going on with them, right? And kids will say, I am experiencing pain or my tummy hurts. And so that's what we latch onto. It makes complete sense. The challenge with that then is sometimes we go down that route. Kids are getting these extensive tests done without really any improvement. And it's interesting because I have a lot of integrated psychologist friends, and the ones who even work in GI, like a lot of those interventions are things that they could start anyways, because ultimately, even if it was an ARFID, if it was a true like GI thing going on, they would still be having to make sure that these kids tolerate discomfort to get adequate nutrition. So in a lot of ways, parents feeling like they have some skills to help coach their kids through discomfort, fear, whatever it might be, but just kind of big reactions at meal times is going to be important either way. So I don't ever want to miss the behavioral health component because we're exploring the medical. We always say too, when kids come to us, like we're never going to ignore all of the things going on with them medically because they're very well, maybe a lot of our kids report chronic abdominal pain, constipation, nausea, all of these things. That's important. And ultimately we need them to eat and we need to figure out a way for them to do that.
I feel so lucky working here at Children's Hospital Colorado, and obviously I have access to so many great specialists like yourself. Not all of our listeners have that. What are some other ways, all the pediatricians out there can address these issues? Are there online resources or other things that they can do?
Yeah, so there are some great online resources. There's some great parent books. The kind of two modalities we use most often for kiddos with ARFID are CBT, so cognitive behavioral therapy for ARFID, which has its own specific manual, and I think is really, they have one that's written not for clinicians, but for parents, so really approachable. And then family-based treatment for ARFID, and family-based treatment is what we do for anorexia and bulimia and kind of other pediatric eating disorders. And it really, again, focuses on those parenting interventions. And so with that, I think just if pediatricians can have access to some of those tools, again, around setting structure in the home, rewards and consequence systems, there's lots of different parent management training programs out there with online systems or just worksheets, all of those things. And so I think accessing those can be great. And so as a pediatrician, really just helping parents understand that like they need to take lead with this. Because I think that's a misconception too, right? Often we're like, well, the kid has to want to change or kid has to want to get better. And with this, like, we're not going to do that. We're not going to let them get so sick with the malnutrition. We're going to intervene even when they don't want to. And so parents are taking the lead with this intervention. Parents are ensuring nutrition for these kids. And the pediatrician can really just be a coach and encouragement to those parents.
You've given us such a nice pragmatic approach, starting in the primary care medical home, then maybe moving to some therapies, maybe a day program after that, more intensive with a psychiatrist, nutrition, those types of things. I think it is worthwhile saying that sometimes these kids end up with an NG tube, nasogastric tube. To get fed even more than anorexia nervosa kids. Is that correct?
Yeah, we do see that. And I often think of that being partially just because of the relationship with food, right? So if I think of someone with anorexia, it's not that they are at the core like aversive to all food, right? And they haven't had that lifelong relationship with food like that. They often were regular eaters before they developed anorexia. And so they can start to gradually reintroduce food. And maybe they have their preferred food still, and some of those higher calorie foods are challenging. But they're still more willing often to just like accept more nutrition. These kids with ARFID, they've done this for so long often and are just so fearful of volumes. That's a big difference we see too, right? It's not the calories in the food that they're really scared of. Sometimes it's a specific food, but even with the oral supplement, they really struggle with tolerating that volume. They're used to eating so much less that any of that kind of GI discomfort that can come up when they're eating more is challenging for them. And so then the nasogastric tube is more of this passive delivery system. And so we see that more in these kiddos.
How often is this presentation handled in primary care versus, therapy versus when it gets really bad and someone ends up in like a day program or even with an NG tube or something like that? How often is that outcome?
Yeah, I think the vast majority can be managed in primary care. That's certainly my hope. that it's caught at that stage before it progresses to us. And then with ARFID, again, I think because of the way that parents can just help increase variety, ensure nutrition in the home, a lot of it can be treated outpatient. Day program is really when we've had that progression to either so few calories, right? We see kids coming in getting fewer than 500 calories a day, where they're really struggling to tolerate any volume, or where there's been such a rupture to the parent-child relationship that starting some of these interventions is just really challenging.
Okay, great. In terms of long-term outcomes, is this something like, maybe it presents in that 8-year-old kid, we kind of get a handle on it, parents feel empowered, child improves. Is it something that's sort of relapsing, remitting type of thing, or is it something they carry with them, more of a chronic thing? Tell us about the long term.
Yeah. So again, when we think of those kids who had more of a chronic course, it is likely to recur. And without continued parental intervention, that can happen. And so often, right, we have that strategy for when they're kids. It's that interesting thing of when they become adults, how do you help adults who continue? Because that's part of it, is we're not necessarily fixing their low interest in food. We're getting them the nutrition they need to grow. And so these sometimes become adults who have to set reminders on their phone, who have to have a really strict schedule for themselves around food because they're just not that interested in food. But it becomes, well, you have to be nourished to be able to do all these other things you want to do in your life. And so, yeah, we can definitely see that.
Well, Kim, this has been such a great conversation. Yeah. I've learned so much about ARFID. It happens in primary care. I feel empowered now. I hope all of our listeners feel empowered as well. We usually like to end our episodes by asking, what is the favorite part of your daily clinical practice?
Yeah. So I work in our day program here at Children's Hospital Colorado. And so for me, and one of the reasons I've always just been attracted to eating disorders work is just how dramatically these kids change. So you really do see these kids, we always say they're like coming back to themselves. As they're nourished, you see them joking and laughing and just being kids again, where often when they land with us, they're so malnourished that they have withdrawn completely from peers. They have damaged relationships with their families. So I just think it's so fun to really see them come back to themselves and interacting with the other kids. And I always say too, like, I always like it when they get like a little sassy or that they're giving their parents some difficulty, because it just shows that they're being kids again. And that's really the goal.
Yeah. Well, thank you for all you do. And thanks for being here.
Yeah. Thanks for having me. This was great.